Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Simply subscribing by email will get you access to that. We also get you info out when we've got new podcasts and new information available as well. So please go take advantage of that at reallifepharmacology.com. All right, the drug of the day today is Bexagliflozin. Brand name of this medication is Brinzavi. And this is a relatively new medication that was just approved here in 2023. It is, as you could potentially tell by the ending if you've got some experience in pharmacology, it is an SGLT2 inhibitor. Mechanistically, how does this work? Okay, the drug inhibits sodium glucose cotransporter 2, and what this transporter is responsible for is that transporter allows the reabsorption of glucose back into the body. So, as you can imagine, that makes blood concentrations of glucose higher. So by blocking this transporter, we're essentially reducing blood glucose and putting more glucose in the urine. Now, what would this be beneficial for? Obviously, it probably makes sense if we're going to lower blood glucose that we're going to use this medication for diabetes. And that currently is the only indication for Bexagliflozin. I believe there are some other studies that are being looked at for other indications, as in some of the other SGLT2 inhibitors that do have other indications, like cardiovascular risk reduction, for example. Heart failure is another good example there. But right now, Bexagliflozin only has the diabetes indication. Dosing is straightforward and easy, 20 milligrams once a day, no titration, no twice a day dosing, anything like that. So that is a potential advantage. But looking at the results and the benefit in management of diabetes, this medication only reduced A1C in the neighborhood of 0.4% in one study. So that's a little bit of a buzzkill with this medication. So, example patient that you might see in practice, they've got an A1C of 9 or 10. Just adding on Bexagliflozin likely, obviously individual results can vary a little bit, but by the studies, Bexagliflozin is not going to reduce it down to where we want to be, around 7 or potentially lower. So, not a crazy potent diabetes agent in that respect, compared to something like, some of the GLP-1s bring it down significantly. Some of the other SGLT2s can potentially bring down that A1C a little bit more. So I'm not crazy thrilled about the effectiveness of this medication. Side effects wise, overall is pretty well tolerated. Like I tell people with supplements and medications, if it's not crazy effective, are we giving enough medication to experience side effects either? So with that said, overall generally pretty well tolerated. The most common thing that I think about with these medications, I do pay attention for any new prescriptions for yeast infections, urinary tract infections, because if you think about it, we're putting more glucose out through the urine, so that is a potential fuel for growth within that area of bacteria and fungal infections and things of that nature. So really, really pay attention to that. If you've got patients with genitourinary infections or frequent genitourinary infections, you've got to make sure to look if they're on an SGLT2 inhibitor like Bexagliflozin. Blood pressure, it did have some blood pressure lowering effects, approximately reduction of 4 millimeters of mercury. Lowering blood sugar makes sense. That's the way the drug works. That's what we're going to be using it for. Possibly can lower it too far, so you got to look out for hypoglycemia. I'd say it's pretty rare if you're just using this medication as monotherapy, but obviously if you add it on top of insulin or other medications, that certainly could be a little bit of a risk. Weight loss was about 1.6 kilograms in the study. So it's nice that it's definitely not going to cause weight gain. The weight loss effectiveness piece of it, it's really not crazy significant, but it is a little bit, which a little bit's better than nothing, but nowhere near compared to what some of the GLP-1 agonists can do. Some of the GLP-1 agonists can reduce or contribute to that weight loss up to 10 to 15 kilograms. So definitely not going to have that weight loss to the extent of GLP-1s. And then there was a reduction in albuminuria, about 20% with this medication as well. Rare adverse effects, euglycemic ketoacidosis. So generally, ketoacidosis is going to happen when blood sugars get above 250, 300, and many times it's way, way higher than that. So if you work in an acute care setting, this is something to look out for, where you might not see a crazy high blood glucose, but the patient could be experiencing ketoacidosis anyway, and particularly might be a little bit more likely if they're on an SGLT2 inhibitor. So pay attention to that, and if you see signs of ketoacidosis, recognize that a drug like Bexagliflozin could be kind of blunting that high blood sugar that we might see with kind of traditional ketoacidosis in patients not taking an SGLT2 inhibitor. Other rare effects that have been reported, limb amputation, necrotizing fasciitis, AKI as well. So again, keep an eye out for those rare, obviously, but serious situations. Few things on kinetics. Half-life is about 12 hours, so we're going to be able to typically get by with once daily dosing there. Primary modes of excretion, urine and feces, and with patients with a GFR of less than 30 mils per minute, we're going to avoid this medication. And the reason being is that that AUC, that area under the curve, really creeps up as renal function declines, which obviously brings in the risk for more adverse effects and issues. So again, avoid this medication in patients with GFR less than 30 mils per minute. Monitoring parameters, A1C, that's going to be a no-brainer. Obviously, we're going to use this medication for diabetes. Renal function, blood pressure, those are going to be the primary monitoring parameters that we're going to look at there. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any board certification study material, like ambulatory care, BCPS, BCMTMS, the geriatric exam, NAPLEX, go check out meded101.com/store, S-T-O-R-E. In addition, if you're taking pharmacology classes, we've got two great new resources, Flippin' Pharmacology flashcards, as well as pharmacology crossword puzzle books. So I'll put all those links in the show notes, as well as at meded101.com/store, S-T-O-R-E. All right, wrapping up with drug interactions. So the first thing I think about is hypoglycemia. If you start Bexagliflozin in a patient on other drugs that lower blood sugar, obviously we've really got to pay attention to hypoglycemia. And that cutoff has typically been defined as less than 70 milligrams per deciliter for hypoglycemia. Insulin, sulfonylureas, those are probably going to present the highest risk of hypoglycemia because they bring that risk on themselves, but certainly adding it to more medications that lower blood sugar, like Bexagliflozin, that's going to increase that risk. I do also think about the diuresis type effect potentially with bexagliflozin and the SGLT2 inhibitors in general. So adding on furosemide, metolazone, hydrochlorothiazide, that can definitely give that additive diuretic effect, which could increase the risk of dehydration, as well as potentially increase that risk for frequent urination, which could be bothersome to patients there. Counteracting the the lowering of blood sugar, you've got to think about drugs that raise blood sugar. Corticosteroids, systemic corticosteroids being the most common medication there. And then last but not least, bexagliflozin, because of the way it works in the kidney, can actually increase the excretion of lithium concentration. So if you've got a bipolar patient taking lithium, we could see an increased risk for treatment failure. So again, causes lithium concentrations to go down in the body when we use a drug like bexagliflozin. So the way I think about this is, how would I manage this, in practice? And I would say we're probably just going to monitor that patient from a clinical standpoint. Are they displaying more symptoms of bipolar disorder, or do we feel like we're failing with our treatment? And that could be indicative of reduced concentrations. And then, of course, the other way to monitor and check this out is you've likely got previous levels of lithium, baseline levels. So we can check a lithium level after they've started the medication for a week or two, see where they're at, make sure they're doing okay clinically. And that's another good way to kind of assess with what's going on there. So in general, with bexagliflozin, unless some new information, some new studies come out that maybe show some benefit in other areas, that A1C reduction is not real potent in my opinion. So I don't really see any strong advantages over any of the other SGLT2 inhibitors, and maybe even some potential disadvantages with less A1C reduction there. So in general, you're probably not going to see a ton of this medication, but again, depends upon if other studies come out and other information come out about some of the older SGLT2 inhibitors, or if new info comes out about this medication. All right, well, I think that's going to wrap up the podcast for today. If you found this episode helpful, leave us a rating or review on iTunes or wherever you're listening. I greatly appreciate that. If you got any questions, comments, feel free to reach out to me at mededucation101@gmail.com. If you're taking pharmacology courses, definitely don't hesitate to check out our resources on Amazon, Flippin' Pharmacology flashcards, as well as the Pharmacology Crossword Puzzle book. All right, thank you so much for listening. Take care, and I hope you have a great rest of your day.